Endoscopic ultrasound-guided choledochoduodenostomy using a lumen-apposing metal stent in a patient with pre-existing duodenal stent and ascites. A 67-year-old female with metastatic breast adenocarcinoma and peritoneal carcinomatosis presented with 1-week history of nausea and vomiting secondary to duodenal obstruction. Liver enzymes were normal at presentation. Upper endoscopy revealed severe extrinsic compression in the second and third portion of the duodenum. 2 overlapping, self-expanding metal enteral stents were placed, traversing the stricture in the duodenum. 3 weeks later, the patient developed painless obstructive jaundice. The total bilirubin on presentation was 8.3. MRI abdomen was performed and showed new moderate to severe dilation of the intrahepatic ducts and common bile duct. Extensive retroperitoneal metastatic disease was seen with infiltrative tumor obstructing the common bile duct and the pancreatic duct entering into the duodenum. Mild diffuse peritoneal and mesenteric soft tissue thickening was noted with trace ascites. ERCP was first attempted, which showed an edematous major papilla found within the metal mesh. Ampulla was suspected at that location but was not confirmed due to the stenosis within the metal stent. Therefore, the biliary cannulation was not possible. This was followed by an endoscopic ultrasound which showed moderate to severe dilation of the intrahepatic ducts and the common bile duct. The common bile duct measured 13.7 millimeter. A mild to moderate amount of ascites was noted in the peritoneal cavity that precluded the possibility of performing an EUS-guided hepaticogastrostomy. Because of the acute angulation and interference of the proximal end of the duodenal stent in the duodenal bulb, avoidance of ascites with a transmural access to the intrapancreatic portion of the bile duct was not feasible. After prolonged examination from multiple locations, a clear window to the bile duct was seen just proximal to the stent within the duodenal bulb, although small amount of ascites was seen in this area. At this point, one-step placement of a small lumen-apposing metal stent was thought to be ideal, reducing the risk of bile leak and allowing adequate biliary drainage. We planned direct EUS-guided choledochoduodenostomy. A long-angled 0.025 guide wire and a 6 by 8 mm cautery-enhanced lamps was used for this procedure. The distance between the duodenum and the bile duct was 8.3 mm, and there was mild ascites noted between the duodenum and the bile duct. The current was applied to the cautery tip, and the bile duct was punctured using cautery-enhanced lamps device through the duodenal wall just proximal to the duodenal stent in order to reduce the occurrence of the bile leak and possible infection of the ascites. The tip was then advanced into the dilated bile duct, and an angled 0.025-inch wire was advanced towards the proximal bile duct immediately. The lamps device was further advanced into the bile duct over the wire. The distal flange was deployed and then pulled towards the duodenum. Subsequently, the proximal flange was deployed, closely approximating the bile duct and the duodenal wall. Excellent bile drainage was confirmed with an endoscopic view. The position of the lumen-apposing metal stent was noted just proximal to the duodenal stent within the duodenal bulb. There was no adverse events noted after the procedure. She had no post-procedural abdominal pain. On next day, she was tolerating soft diet and her total bilirubin was down to 2.6. She was discharged home on 7-day course of antibiotics. At 3 months follow-up, the patient was clinically doing well with normalization of the total bilirubin. EUS-guided choledochoduodenostomy was relatively smooth with the new smaller format of lamps given the flexibility of the device to deploy the stent. The benefits of smaller format is that it allows the insertion of the stent in a small window of stent placement and the short distance that it needs to be advanced into the duct. This is a great advantage for EUS-guided choledochoduodenostomy because it fits the angle it usually needs to conquer. that is the angle of needle insertion to the duct towards the hilum. In this case, mild to moderate amount of ascites was noted during EUS evaluation. This was a concern, but direct access single step stent placement was effective with no post-procedural pain or infection. Direct EUS-guided choledochoduodenostomy with the smaller configuration of lumen-apposing metal stent was successful in this difficult patient with ascites when other endoscopic interventions were not technically feasible. Smaller caliber of the stent helps target the small window proximal to the duodenal stent, avoiding the stent-in-stent insertion. This may also contribute to the reduction of some syndrome. One-step placement of fully covered lumen-apposing metal stent likely would minimize the chance of bile leak, making this device ideal for the procedure.